in health services development. It's my great privilege and honour to actually have been invited to chair this session and chair it jointly with my colleague, Professor Chow Han-Yi. We have 4 speakers, and what we would like to do is to run through their presentations consecutively with a session at the end for questions. So, without further ado, I will introduce the first 2 speakers. My colleague, Professor Chow, will introduce the next 2 speakers, and then we'll end with the questions. So, first, may I call on Miranda Sade, who is a senior scientist and coordinator of the Nutrition in Life course in the Department of Nutrition for Health and Development of the World Health Organization in Geneva, Switzerland. She has a huge experience over many, many years in child feeding strategies and policies, and we look forward to hearing what she has to say. Miranda.
Good afternoon, everyone. It's a pleasure to be here and to present to you this baby and mother-friendly care. Thank you very much for inviting me and for giving me the chance to talk about this kind of a strategy and initiative. I'll be going through the presentation as we have very limited time, 20 minutes. I'm going to go through it a bit quickly than I usually do. But I want to remind you that we do have a workshop tomorrow specifically on baby-friendly, and much of the ideas and strategies and pathways and all the child survival and mother-friendly issues that I'll be going through here quickly, we will be presenting more at length tomorrow. So I invite you all to be with us tomorrow as well. Within the UN and within WHO, whatever we do is to improve the survival, growth, and development for all children in the first 3 years of life. And working in baby-friendly, one objective is to actually achieve that. And when we do that, we are actually contributing to the Millennium Development Goals. And this is very important for all health workers working in the area of nutrition and health. We know now that breastfeeding is one of the most cost-effective interventions for reducing under 5 mortality. And we can see here achieving exclusive breastfeeding is actually #1, achieving 13% reduction in under 5 mortality. And many series and publication and evidence have become out now to tell us the importance of the neonatal period. And the recent Lancet Child Survival Series on neonatal health also indicated that more than 2 million deaths between 1 month up to 5 years old children die from infectious diseases that could easily be prevented by simple measures like skin-to-skin contact and improved breastfeeding. And the skin-to-skin is actually one step of the baby-friendly hospital that we're going to talk about. We also know that much of the growth faltering happens during this early period of life. So any intervention that will make a difference in our children's life will have to start early. We call it a window of opportunity, and this is from pregnancy up to 24 months, -9 to 24 months. So much of the efforts we're focusing on within WHO and other UN organization is actually this kind of window of opportunity, and baby-friendly fits very well within that window. We also, collecting the data within the WHO, we also know that the rates of exclusive breastfeeding at 6 months, which we aim for, is still very low. And if we look here, the third one, exclusive 6 months, we see 36%, which tells us that about 2/3 of our children are really not getting the ideal feeding recommendation that will give them the best start in life. So actually what we aim for, whether it's baby-friendly or any other initiative, within that window of opportunity is achieving exclusive breastfeeding for full 6 months, 180 days, and then the early initiation of the breastfeeding, the skin to skin, and actually continuing to breastfeed well into the 2nd year of life. Not forgetting the introduction of appropriate, adequate, and safe complementary food at the end of 6 months. So much of what we do in this area is also trying to achieve this global infant feeding recommendation. Like I said, baby-friendly is one of the most effective interventions that WHO now is focusing on and revitalizing within the infant feeding area of work. And actually it is one of the 9 targets put down in the global strategy for infant and young child feeding. And you can see the target listed as ensure that every facility providing maternity services fully practice the 10 steps. And this is the baby-friendly. So what is baby-friendly? When it was launched in 1991, the main idea of baby-friendly is to ensure the best start in life for all babies by creating the appropriate healthcare environment where breastfeeding is the norm. And this is also changing healthcare system as it is stated in the global strategy. You can always go back and read that paragraph in full. And this is here, I put direct and a clear link to what the HPH, the Health Promoting Hospitals ideals are. So implementing baby-friendly is actually a changing process. We're changing the maternity practices to enable mothers to breastfeed and to enable the health workers to give the best advice to the mother. It is transforming all the maternity wards according to a standard global criteria and the 10 steps, as well as ending the distribution of low and free cost supply of breast milk substitute. It is very high on the health agenda, as I said, and it has been passed in the recent resolution last year, where the Assembly called for all member states to give effect or to implement the 10 steps and the baby-friendly. Right now we have about 20 to 22,000 hospitals baby-friendly in about 152 countries. These are the 10 steps, and they are listed in a joint statement, WHO-UNICEF statement on maternity services. I won't have time to go all through the steps, but I'll just give you some examples. There is a global criteria that all countries need to apply, and it is the same whether we're talking a country in Zimbabwe or in Sweden. The global criteria applies everywhere, the same. All the documents and the material have been streamlined into one package that you can also access on the web. Example of some recent changes. As we go through the baby-friendly, we update the evidence. For example, for step 4, it used to be start breastfeeding within half an hour, but now it is place the baby skin to skin with the mother till the baby is ready to breastfeed. So this is one kind of example of an enhancement done to the step and the criteria as we go along. We also know that the early initiation of breastfeeding will have long-lasting effect on the breastfeeding. The breastfeeding rates will be higher at 3 months and 6 months, and not only within the hospital doors. There are many reasons for that, and this will be discussed at length tomorrow. So baby is left undisturbed to follow the normal sequence of innate feeding behaviors and initiate breastfeeding when the baby is ready. We don't push the process. We let the baby. It is a baby-led process, and the first breastfeed will be initiated when the baby is ready. Skin to skin is what counts, and this is what saves lives. And by doing that, we stimulate the love hormone, the oxytocin release. The kangaroo method is very much encouraged within the new material, and even for low birth weight infants, it's very, very important. The father, we strongly suggest the father takes a role in that, whether it's the kangaroo or the rooming in. And I like to stress here the great role of the father. Also, we emphasize the cup feeding, milk expression and cup feeding, and this is all within step 4. Other steps that have been enhanced, like steps 6, 8, and 10, and we'll look at that again at the workshop tomorrow when we have more time to see what are the medical reasons for supplementation. The code is very important, the code. And many, many health workers actually don't know how the code relates to the baby-friendly. And this is the compliance with the code is very important, not accepting discharge packs, the samples, the sponsorship, the compliance and gifts, and so on. So the code is also an integral part of the baby-friendly. The concept has caught on, and now we are expanding and integrating baby-friendly. And one way of the integration is actually the mother-friendly. This has been recently added to the baby-friendly, and now we know it is baby and mother-friendly, and actually you cannot separate the two. And mother-friendly, it talks about the policies and that required mother-friendly labor and birthing practices and procedure. And actually, when we do the assessment for baby-friendly, we do the assessment for the policies and practices about mother-friendly. For example, just quickly, some of the policies encourage women to have companions of their choice to provide continuous physical and emotional support, allowing the mother to eat and drink during labor, encourage the woman to consider the use of non-drug methods of pain relief, and encourage the woman to walk and move about during labor if desired, and choose the position she feels most comfortable at. It does not involve care that does not involve invasive procedures such as the rupture of the membranes, episiotomy, and so on are also mentioned there within the mother-friendly. Everything we put as a criteria will be carefully assessed when we do the assessment in a hospital to officially designate that hospital or institution baby and mother-friendly. Now, the effect, like I said, have been shown, the changes way after discharge on breastfeeding, much higher at 3 months and 6 months, and the duration is also longer when we actually do it right and start the baby-friendly right. Sometimes the effects are seen within months, like this example from China, where the rates of breastfeeding at discharge has increased between April, July, and November. It's very good to document your progress. There has been for baby-friendly a lot of economic benefits, and this is a study done in Philippines where having baby-friendly can save up to 8% of the hospital budget. So some economic benefits is there as well. Also, not forgetting that on the wider range change a wider picture, there will be some savings done at the national level. And this is example from the US, where billions of dollars could be saved if baby-friendly is right and if we succeed in establishing exclusive breastfeeding for 6 months. I don't want to leave the chance but to mention the link to non-communicable disease and breastfeeding and exclusive breastfeeding that baby-friendly contributes to that, because we know that babies who are not breastfed are 22% more likely to become overweight and obese, and this has the evidence behind it. I was a bit disappointed yesterday when there was a plenary talk, and we talked a lot about obesity and diabetes and so on, and coronary heart disease, but breastfeeding was not mentioned as one of the first diet any human being can do, and this is very important. Now, the standards of healthy promoting hospitals, are they in line with baby-friendly, and can we create a partnership? Definitely yes, because we follow the same kind of criteria. We require a policy, we have standards for assessment, reassessment, and monitoring. We do information sharing and intervention and sharing all the material with the mothers, and we sustain progress by having some documents and tools to ensure the continuity. And this is kind of a route, a standard route to become baby-friendly. Now, strategically, baby-friendly means, what does it mean for management? I think it means is a quality improvement project. That's how we need to look at it as well. And it is part of the hospital's total quality management program. Now, in short, if I can summarize, baby-friendly is central to a comprehensive, multi-sector, multi-level efforts to enable every mother and family to give every child the best start in life. It has measurable and proven impact and will increase the likelihood that breastfeeding will be achieved for 6 months. We have a global criteria for baby-friendly. It provides a standard where we can do the assessment, and it is the criteria can link with other quality assurance systems. In countries where baby-friendly has been successful, it has been included as part of the hospital accreditation system. They sustained the progress they made this way and were able to move ahead. I think I compared here, I'm not going to read it, but I'm going just to say that it has very close link to the concept of HPH, baby-friendly and HPH. They build upon the health promotion concept of WHO Ottawa Charter for Health, and I liked here, I took it actually from an abstract from Christina, Jürgen, and Carr, where they said the HPH network will have now to take into account some major changes that have occurred in the hospital landscape since the start of the network, and the increasing importance of evidence-based medicine. And we do have, we're going to present to you the baby-friendly with all its evidence. I think I'm going to leave with a proposition and recommendation to the Secretariat here and the 20th Task for Work Group Committee of HPH. I think we need a task force between HPH and baby-friendly. This task force is timely and very much due. We know what to do, we have the evidence behind it, and we really need to make that link to move forward and move steadier in what we're trying to achieve. This is a useful link that you can see, and I thank you very much for your patience. I know I went very quickly through some of the ideas, but this is a good point for you to come tomorrow and discuss it more in the workshop. Thank you very much.
Thank you very much, Randa. And if, as I say, we will invite questions later on. If I might move on to our second speaker, my introduction, Julia Puebla-Fortier is the Executive Director of Diversity R, which is involved in professional education resources on cross-cultural healthcare. She works for a non-governmental organisation that promotes good policy, practices and research on healthcare for minority, migrant and indigenous populations. She's going to take us through some issues around migrants and disadvantaged population groups. Welcome, Julia.
Good afternoon, and I'd like to give my thanks and congratulations to the conference organizers for hosting this excellent conference, and a very special thank you to the people of Taiwan for the warm hospitality that we have received. I'm very pleased to talk to you today about a very important issue and an opportunity for hospitals and healthcare systems around the world: the globalized patient, how to adapt healthcare systems for mobile, migrant, and minority populations. My name is Julia Puebla-Fortier, and I'm the Executive Director of the non-governmental organization DiversityRx, Resources for Cross-Cultural Healthcare. In many ways, I'm an example of the globalized patient, the child from an immigrant family who grew up in the United States and has lived in England, Switzerland, France, and now Japan. The mandate of DiversityRx is to improve the accessibility and quality of healthcare for a diverse and globalized world. We support those who develop and provide health services that are responsive to the cultural and linguistic differences presented by mobile, migrant, and indigenous populations. Active in the United States, Europe, and now Asia, DiversityRx has worked with hospitals, universities, philanthropic foundations, government agencies, and international organizations to develop policy, raise awareness, and develop strategic collaborations. Through research, conferences, and the internet, we collect and disseminate information about model programs and policies around the world. So let's begin. Imagine this scenario. You've gone to a conference in another country. After a long day of meetings, you find yourself struggling to get words out properly. Your right arm feels heavy and weak. You make your way to the conference reception and manage to ask for an ambulance. But will the paramedics speak your language? When you get to the hospital, will the staff be able to understand the subtleties of your emerging symptoms as you try to describe them? Will you be able to explain your past medical history? Will you be able to discuss treatment options with the physician in charge? What if you're a young man from an indigenous village and you need to go to a hospital in the big city? Or you are a domestic worker from another country and you become ill? Or an international student injured in a motorcycle accident soon after you begin your studies? What happens when a person gets sick outside their own country or hometown is an increasing global phenomenon. The impact is faced every day by hospitals and healthcare providers, sometimes multiple times a day. There are 214 million international migrants. That would be the 5th most populous country in the world. 922 million business and recreational travelers, 10.5 million refugees, and 27 million internally displaced people. Millions of men and women who leave their homes to work or get married in another country. Increasing incentives to develop services for medical tourists. And because they speak different languages or have different cultural practices, minorities and indigenous people often experience the same barriers as mobile populations. Now, I'd like to make a distinction between vulnerable populations and more privileged populations. There may be more incentive to serve some population groups and disincentive to serve others. But many of the needs are the same and can be met by some of the same interventions. This is the globalized patient. And as healthcare providers, policymakers, researchers, and advocates, we are called to serve them. So let's review the goals of the healthcare delivery system. As administrators, clinicians, and staff, this is what we are trying to achieve with every patient and in every setting. Preventing disease and promoting health, improving quality, reducing errors, efficiency and cost effectiveness, good health and fostering good patient and community relations. But the globalized patient presents certain challenges. Access to and appropriate utilization of health services can be compromised by confusion about enrollment processes and entry points. The globalized patient may find it difficult to communicate symptoms or understand treatment instructions due to language barriers. This can be complicated by different cultural views on how illness should be managed or lack of familiarity with a formalized healthcare system. Many migrant and minority populations experience discouraging or discriminatory treatment by staff. And healthcare professionals may not be prepared to identify and manage a variety of health issues presented by the globalized patient, including communicable diseases, inherited conditions, and the effects of displacement, trauma, torture, or sexual abuse. Equally challenged are the structural barriers to care that may affect some patients. Migrants and international students may not be eligible for health schemes outside their home countries. Business travelers and tourists may not be able to use their own health insurance. Undocumented status renders many people ineligible for any services in some countries and subject to deportation or detainment if they are reported. Having to pay for health services out of pocket is a serious and often life-threatening barrier for low-income workers. And individuals in rural or undeveloped regions may not have access to the full range of health services. So how can we achieve healthcare goals for the globalized patient? My presentation will focus on model practices and policies already in place around the world. These programs have been developed by collaborations of practitioners and patient representatives and are increasingly supported by research and policy frameworks. I will conclude with a discussion of how strategic alliances involving key stakeholders can bring us closer to the goal of providing quality health services for the globalized patient. Because I only have a short time to talk to you today, I've prepared a resource document that will give you much greater detail on these and other models. You can access it online at the webpage that you see here. Let's look first at the practice realm. We are all familiar with the concept of patient-centered care. This is a central concept in meeting the needs of the globalized patient, but with some important adaptations to address their unique needs. To address the most critical issue of communication, medical interpreter services and translated written information are needed to deal with language barriers. Clinicians need a professional manner in the clinical encounter that is sensitive to and informed about the epidemiological factors, cultural background, and social determinants that may be different than that of native populations. Health promotion, disease prevention, and disease education and support programs that are tailored to the linguistic, social, and cultural needs of specific patient populations. Cultural support staff that can explain and negotiate cultural issues related to health and illness. These approaches are not one-size-fits-all, but proven interventions that improve the ability of patients to participate in and benefit from health services. Extensive published research demonstrates the impact that they have on patient satisfaction, healthy behaviors, adherence to treatment, reduction of medical errors, and improved clinical outcomes. There are hundreds of examples of these interventions in action around the world today. Let's just focus on a few. There are many ways to bridge language barriers between patients and healthcare providers. Evidence shows that formally trained and compensated medical interpreters provide a higher quality of service with fewer errors of clinical consequence than using friends or family. However, it can be logistically difficult to find, train, and deploy interpreters where they are needed. Using telephone, video, and mobile technology to link interpreters from many locations is proving to be cost-effective and practical. This approach is being widely used in the United States and Europe and is a way for a network of hospitals, health departments, and clinics to share interpreters across many institutions. At this conference, we've already heard from a group in Japan that is developing a video interpreting application that can be used on many platforms, including smartphones and Skype. This is complemented by a growing medical interpreter association that is working to increase awareness about using trained interpreters to meet the language needs of foreign residents, business travelers, and medical tourists. A very effective model of care that directly addresses the linguistic and cultural issues posed by the globalized patient is the use of cultural support staff, working both inside health organizations and out in the community. They may be called intercultural mediators, community health workers, or patient navigators, and are used in many countries and in a variety of contexts. These cultural support staff can play a wide range of roles, such as interpreter, patient advocate, and health educator, and serve as a resource to clinical staff when cultural issues arise in the course of treatment. One of the pioneering programs began in Belgium. Supported by the national government, it currently funds 80 mediators in 62 hospitals around the country, where they provide interpretation services and patient support. They are now implementing a remote video interface to extend the availability of these mediators to more patients and other hospitals. In Hamburg, Germany, teams of intercultural mediators plan and conduct health promotion events and community learning sessions, including an introduction to the German healthcare system for migrants. There are 21 programs in other German cities funded by a national collaboration of health insurance companies. It is critical to prepare the health workforce to understand and effectively interact with the globalized patient. It should include training for clinical support and administrative personnel, and it can take place on the job and in professional education. Some of the training should include the epidemiological context of mobile and minority groups, responsiveness to linguistic and cultural issues, non-discrimination, and rights to healthcare. Responding to the large number of foreign nationals working in Qatar, the Weill Cornell Medical College with the Hamad Medical Corporation has implemented a cultural competence training program for medical students to prepare them to work with diverse populations and to support the effective use of its medical interpretation program. In other areas, cultural competence training is being required in both health professions training and continuing education. Another strategy is to develop career pathways for immigrant health professionals. It's often very difficult for these migrants to use their training due to license barriers in many countries, but they can be a valuable asset because of their language skills and cultural understanding. In Portugal, with funding from a national foundation, Jesuit Refugee Services assisted immigrant physicians and nurses by facilitating their professional integration through the many complicated stages of administrative procedure and academic requalification. A similar effort in the United States, the Welcome Back program, has helped more than 2,000 migrant health professionals move towards requalification or employment in the healthcare sector. The key to long-term improvements in the delivery of healthcare to the globalized patient lies in formal systems of programs and policies in mainstream healthcare organizations, as opposed to ad hoc, short-term, individual projects. These strategies must engage health staff from all disciplines and areas of responsibility and address all levels of health planning, service delivery, management, and governance. There's an emerging field of policies being implemented around the world that address these issues, from professional accreditation to policies and regulations to international initiatives. Let's look at a few examples. There's been a lot of activity on migrant health at the international level, a sign of the growing concern about how globalization and diversity is affecting hospitals and healthcare systems around the world. The WHO HPH Task Force on Migrant-Friendly and Culturally Competent Care has been developing a comprehensive framework for measuring and monitoring the capacity of healthcare organizations to improve healthcare for migrants and ethnic minorities. The final product will be a self-assessment tool that allows healthcare organizations to carry out their own equity evaluation against a set of standards and to stimulate improvement. We are lucky that the project leaders, Antonio Chiarenza and Bernadette Kumar, are here at the conference and have given a talk this morning about standards and the upcoming pilot test. The World Health Organization has also taken up the issue of migrant health, first with a resolution passed by the World Health Assembly in 2008, followed up by an international consensus-building initiative co-sponsored with the International Organization for Migration. The consultation report lays out the operational framework for priorities on monitoring, policy, services, and partnerships to improve healthcare for migrant populations. Countries have been equally active in this area. Over the last 20 years, several countries have implemented policies and regulations to improve the quality of care for diverse populations, including increasing access to health insurance and adaptation of health services to be more culturally and linguistically sensitive. In Spain, all migrants, including asylum seekers and irregular migrants, are entitled to the same health coverage and conditions as nationals. The Valencia Health Agency in Spain has a population information system that allows the collection and matching of data about nationality, residence, insurance status, and various health indicators to permit analysis of each distinct cultural or national group with any public health issues that may emerge in that population. In Australia, in the state of Victoria, they have a very large foreign-born and Aboriginal population. The Department of Health has developed a cultural responsiveness framework with standards and targets for all health providers. And in the United States, the Department of Health and Human Services has issued voluntary standards for healthcare providers on culturally and linguistically appropriate services in healthcare, the class standards. These are backed by civil rights law that prohibit discrimination by national origin and require interpreter services in hospitals and clinics. Professional accreditation is a powerful tool to shape the behavior of healthcare organizations and health professionals. Most notably, the Joint Commission in the United States, which is the required accreditation agency for all hospitals, has issued patient-centered communication standards for hospitals, which are now being surveyed on. The standards address issues such as qualifications for language interpreters and translators, identifying and addressing patient communication needs, collecting patient race and ethnicity data, and non-discrimination in care. In New Zealand, the Health Professional Competency Assurance Act of 2003 requires that health professional registration bodies set standards of cultural competency, clinical competency, and ethical standards, and to ensure that practitioners meet these standards. Also in Canada, nurses are being asked to review and participate in a set of cultural competency standards for their professional accreditation. So let's turn now to strategic alliances, how we can use collaborative efforts between stakeholders to improve healthcare for diverse populations. All the programs and policies we have just discussed are the product of partnerships between a variety of interest groups. In some cases, they were started at the community level or by individual hospital departments, but they have scaled up by raising awareness among decision makers and getting the broad support of healthcare staff and community representatives. Using the example of models that work, advocates are able to work with health professional organizations and policymakers to craft policies that will institutionalize good practices across the healthcare system. These are some of the important stakeholders to consider in developing strategic alliances. Health professional bodies, both clinical and hospital associations. Health policymakers, both local and national administrators and officials, as well as legislative representatives. Cross-sectoral actors, including those in social services, education, labor, and economic development. Community and patient representatives, and local, national, and international non-governmental organizations. The last few years have seen increased attention to the health needs of migrants, minorities, and other populations. We have documented good practices, policy frameworks, research findings, and the effect of health inequalities. In some countries, the dialogue about these issues has evolved over time and is maturing. In other regions, the dialogue is just beginning. There are many opportunities to advance this agenda. One significant gap in most countries is the lack of coordinated action to comprehensively address the needs of the globalized patient within the context of existing healthcare programs. This includes removing legal and financial barriers to the system. We must replace one-time demonstrations or short-term projects with consistent funding, and the results of successful demonstrations must be integrated into regular service delivery systems. There's also a great need for comprehensive and accurate information about this population's health needs and how to meet them. The models and documentation exist, but mainstream healthcare providers and policymakers are still largely uninformed. This information should be integrated into health worker education and made part of professional societies' meetings and agendas. Coordinated systems for collecting and analyzing data related to the health needs and status are still mostly lacking, but they are necessary for effective planning and evaluation of quality care. It's also critical to identify and package the key elements of migrant and minority-sensitive health systems for inclusion in other important health agendas, including primary healthcare reform, initiatives related to major disease programs, population-specific programs, and quality improvement programs, including patient-centered care and patient safety. Global networks and regional professional associations can be used to document and share best practices. Quality for the globalized patient is an achievable goal. In order for hospitals and healthcare systems to achieve their overall quality goals, they must provide quality services to all patients. Models from around the world show us that quality healthcare for the globalized patient, migrants, mobile, minority, and other vulnerable populations is achievable. Let's use these examples to examine our current practices and policies and build strategic alliances to improve access and raise the health status of all. Thank you very much for your attention today. I'd be very happy to discuss your own experiences and talk about your questions about how to adapt healthcare systems for the globalized patient. Thank you very much.
Thank you, Julia. And the next presenter, Dr. Clement Hausman. He is a professor of mental health promotion and prevention of mental disorder at Maastricht University and Rotterdam University. And his research centers on prevention of depression, prevention of transmission of mental disorder from patient to children, community intervention, effectiveness and effective moderation in mental health promotion and mental disorder prevention, guideline for promotion, development and effect management, capacity development, policy making and innovation. Let's welcome the Professor Clement Hausman. He will talk about the contribution of health services to mental health and mental health promotion. Let's get a big hand for Professor Clement.
Good afternoon, distinguished guests, ladies and gentlemen, dear colleagues and friends. I very much, let me first say how happy I am that I'm at this conference. I think it's a very inspiring conference. There is a lot of exhibition of health promotion in Taiwan and in many other countries that also inspires me. Also, I am already working in this field for more than 40 years. It's still an exciting experience to share with so many cultures the best products and the best ideas. I very much appreciate that mental health promotion, including prevention of mental disorders, is put on the agenda of this conference. I would like to thank the organizers, and especially Professor Harmut Berger, for inviting me to this conference. And I also want to thank the Honorable Mr. Xu, the Vice President of Taiwan, for explicitly stressing in his opening address the need to give mental health a high priority on the health promotion agenda. Worldwide, and also in Taiwan, there is an urgent need to find innovative ways to address public mental health issues. Many countries are facing a dramatic increase nowadays in the demand for psychiatric treatment. Recently, I saw a publication of Dr. Wang from Taiwan, who reported an 8-fold increase in the number of psychiatric patients in Taiwan over a period of 12 years. In a way, this could be considered as a success. The success of all the actions from the World Federation of Mental Health, from the World Health Organization, the Psychiatric Association, but also from many, many local psychiatrists, social workers, and consumers who have advocated for a destigmatization of mental health. And although mental health services have been expanded as a result of that in many countries, and also in Taiwan, that growing demand for such services is becoming almost unpayable. Apart from the question if it's a wise idea to bring more and more people, millions of people, to psychiatry. I give you just an example of my own country. When I started my work around 1970, In the Netherlands, a country now of 17 million people, around 100,000 people in a year made use of mental health services. Last year it was grown to 1 million. 1 million people from the 17 million who went for help to mental health services. This is a tremendous problem. The question is, do we want that? Is that indeed a success, or do we want to get so much people sending them all to a psychiatrist and not to their neighbor or to their community or to others who could help them? So these alarming developments ask for innovative answers, and especially in a period of economic recession. The question is thus, how could hospitals and health services contribute to mental health promotion? It's a timely question. And I will share with you some ideas about possible answers and arguments for it, and also the question, why should we do it? So it's interesting that this question was not only raised by the health promotion hospital network. They recognize that mental health should get a higher priority than till now in the network. It is also raised by the international community of the many prevention experts, health promotion, mental health promotion experts, and researchers and policymakers and advocates who now face the situation that we do have a lot of interventions available, but they don't reach the public. There is a huge implementation problem. So maybe health services, hospitals, could be of help of being a provider, not only of care, but also of prevention and promotion. It was also a question raised by the psychiatric community, who are now, as I said, facing a kind of a crisis worldwide in the overload of patients in mental health services. So also they are looking for innovative questions, innovative solutions, sorry. While probably a range of you, maybe a majority of you, are not working in the field of mental health, I would like to convince you that this is indeed a priority. Let's go after some figures. Mental disorders are highly prevalent. It was already said in an earlier presentation this afternoon. 450 million people in a year in the world having a mental disorder. These mental disorders and mental problems have a serious impact on individual life, on family life, on professional life, on social life. It has a tremendous impact, as I will say later, discuss later, on the children of mentally ill parents. They are one of the group at the highest risk of getting also these kind of problems. And this is not just a question of genetic influences. It has a lot to do with the relationship between parent and children. So what could we do about that? The problem is also creating large economic cost to societies. I just got a publication that was released a couple of weeks ago by a group of international experts, and who computed that in 2010, $2.5 trillion dollars were the cost of mental problems in the world. If we think about, and this figure will grow in the next 20 years to around $6 trillion dollars. If we could get only 5%, let's say $10 billion to put in prevention, that would make a huge change. So we need to think about changing money streams. It's likely also that mental disorders impair our immune system, create more vulnerability to chronic diseases, poor illness recovery in hospitals, in non-psychiatric patients, increased mortality. So I already stressed the demand, increasing demand of psychiatric care, and still, notwithstanding this increase in demand, we know from research that there is still a large group in society who don't get any professional help. We do have knowledge about malleable risk factors and protective factors for mental health, mental disorders. We do have nowadays effective prevention and promotion programs available in this field. So why invest in mental health? I not only want to refer to the problems, to the disorders, to the diseases. It's also about good mental health. Good mental health, we realize more and more, and also more and more politicians, at least in Europe, is a cornerstone of human, social, and economic capital. It has an impact on quality of life, well-being, better health, less chronic diseases. It has a known impact on academic achievement, on getting a job, on productivity in work, on citizenship, social participation, safer communities, violence, and so on. So mental health represents a huge value for us all. Important is in the next story that we make a differentiation between mental disorders on the one hand, that we like to prevention, and on the other hand, positive mental health. And talking about positive mental health, I'm referring to emotional resilience of people, self-esteem, positive outlook, competence, social competence, cognitive competence, problem solving, social skills, stress management, meaning in life, having a feeling for humor, and so on. And these factors have found to be malleable. It's not that of course, you are born in a way, and so you are inclined to be maybe more pessimistic or optimistic. But many of these factors can be changed. Let's look for a moment to the progress that has been made over the last, 20 years. The first ideas about prevention and advocacy for prevention of mental disorders and promotion for mental health were 100 years ago. Clifford Beers, a mental patient, stood up, wrote a book about his experiences, and traveled all over the world in the beginning of the last century, around 1905, 1910, 1920, to advocate for mental health and for prevention. It took then another 50 years before the first books about how to do it were published. In the last 20, 30 years, a tremendous amount of research and experiences in practice, and exchanging around the world those practices, the best practices, the model programs, and so on. And it has delivered a huge package that we now have available to implement. It needs to be expanded, it needs to be improved, that's okay, but we do have already a lot of tools available. Research showed that these programs can be very effective. They need to be improved in terms of efficacy and effectiveness, but a lot of preventive effects have been, and mental health promotion effects have been found, and there's evidence for that. And those programs are now described in several countries, also in my country, in databases that are accessible for everyone who is interested in that. Description of the programs, description of the evidence, advice about how to implement it. So it's available for hospitals, available for health services. It shows also that there are many different benefits from these kinds of interventions. Better mental health, also less mental disorders, an increase not only in relapse or in reoccurrence, but also in the first incidence of mental disorders. Better health, but also many social and economic benefits. And some studies now show that those in randomized control trials that those effects are sustainable. Some effects are found till 50, 40 years after that. These are the topics. I will not discuss them all, just to give you a picture about where this field is all about. It's about preventing mental disorders, and these are the disorders for which there are now programs, beginning programs that show beginning effectiveness. Just as an example, if you focus at people who have depressive complaints but not depressive disorder, there are now cognitive behavioral training programs that you can do at home, through internet, or in a group, or through a book, and so on, that have found to be effective. And it was found that across 90 randomized control studies, that these kind of interventions reduce the incidence of depression with 22%, so 1 in 5. That's a huge effort and a huge success in my view. There are a lot of programs focusing on mental health, especially targeted at children, school programs that are indeed increasing. Oh, sorry. So the emotional resilience programs, social competence programs, and so on. Those programs show that if you increase these kinds of competences, for example, aggressive behavior, aggressive bullying is going down. There are interventions for specific populations at risk. I already talked about the children of mentally ill parents. Children of mentally ill parents, we have found, is the next generation of psychiatric patients. Let we go it. Should we take a stand? Should we do something? We can do something. And now there are developed worldwide, and we have a whole international network, a range of interventions to reduce the risk factors and to empower those children, to prevent that they get generation after generation the transmission of psychiatric problems. There are interventions that show a huge reduction of domestic violence. Okay. It's also not only social, mental outcomes, it's also about social and economic outcomes. As you can see here, these programs, better mental health, results also in these kind of outcomes. Now, what can mental health and health services, what can hospitals do to prevent mental disorders? I've here made a list of ideas, and several of these ideas are already in practice. Some of the ideas need still further to develop. The first recommendation is provide available, we do have a lot of available model programs that are found in studies all over the world, frequently developed in practice, studied, found to be effective, improved, and let's use these kind of programs to adopt them by hospitals, by health services, and implement them. In hospitals, there is also a huge task to screen mental health risk among patients that are in a hospital, not for a psychiatric disease, but for cancer, coronary disease, diabetes. In these diseases, in these patients, there is a lot of comorbidity with mental problems. I want to recommend that there is, in health promoting hospitals, a more developmental focus. What I mean is to increase resilience and reduce vulnerability in new generations. We know that stress, that depression, that anxiety in women who are pregnant have, through the hormonal influences, a direct impact on the developing brain of the new child. Many of these children are born vulnerable, psychiatrically vulnerable, because of this experience. We can make a change. There are now programs that could reduce stress and depression during pregnancy. We are developing still new ones and do research on that. I already refer to the children of mentally ill parents or other chronic parents. We can make more use of the modern technology. E-health is a worldwide booming business. E-health is using internet to help people, to empower communities, to empower individuals to take care better for their health, to have more knowledge, to have more skills. In my country now, mental health services have decided that in the next coming 4 or 5 years, almost 30% of all treatment has to move to internet. There is a lot of research done now that shows that preventive interventions, treatment interventions through internet are as successful as individual therapy. Many therapists don't believe it, but randomized control studies show that it's true. You can reach much more people by internet. It's much cheaper. An hour therapy, the therapist could not do 2, 3 times or 100 times patients in the same hour. But 1 hour of internet availability of a good program could serve hundreds of thousands of people. That could make a change. That could solve also economic problems in mental health. We have a stepped care strategy. A stepped care strategy means that you combine very simple programs with, that you offer to a large group of people, among others through internet, and then have kind of a stepped care, more complex, more intensive, and then more specifically focus on those patients that really need intensive treatment. In a study in the Netherlands, among elderly, it was shown that such implementation of such a system prevented 50% of depression cases in elderly. Community-based work, citizen involvement, community involvement, and is also a very new area. Also here in Taiwan it's used. And I would like to go now to, this is the new task that mental health services hospitals should adopt. Also collaborate, developing coalitions, not only treating an individual education, but also giving training, developing competence in the communities, using media. We are developing now a soap series on mental health issues in a local community, a television soap, to reach much more people, and consultancy to policymakers. If you use this, I have just 2 slides, the last 2 slides. This is an example of capacity building, which is a new task of mental health services. If you train as mental health services, instead of giving therapy to all your patients, if you train district nurses, which was done in the UK by Terry Brugger, it was shown that by training district nurses in recognizing depression early, but also helping at home the patients to treat them with depression and not refer them to a psychiatrist, it has as a result a reduction of 1/3 of all new cases of depression in high-risk groups. Last slide. To make this all happen, we need to create the conditions. We need policy changes. We need reformulations of the task of mental hospitals, new type of mission statements, away from the traditional just giving individual care. We need really to invest in capacity building, in leadership development in countries, in districts, to get this on the move. So we need to train people in health promotion, but also in mental health promotion and prevention of mental disorders. We need to change financial structures. We need to negotiate with health insurance companies all over the world that's in their interest not only to pay for individual treatment, but also to invest money in prevention and promotion of population. And finally, we need good examples, good knowledge, research, to develop inspiring models that we can share. And I'm very grateful to hear all the excellent examples that you have developed in your community. Thank you very much.
Ni hao. Distinguished guests, fellow speakers, colleagues and friends, it is an honor to be here to address you this afternoon. And I want to thank especially the leadership of the HPH Network and Dr. Chu and the Bureau of Health Promotion for inviting me here today. And it's been an excellent conference so far, and I hope I can make a small contribution to it. So I want to start with a small question here. Sort of a rhetorical question, if you will. Can you have healthy people on a sick planet? And the answer, in the words of sages and scholars down through the ages, is it depends. It depends on what you mean by sick, and it depends on what you mean by healthy. So let's do a quick rapid-fire diagnosis of the state of the planet. It appears that planet Earth has a problem with NCDs. We have a severe case of chemical dependency, where our energy is derived primarily from fossil fuels. Our pharmaceuticals are derived from fossil fuels, in part. The plastics that make our computers and many of our other devices are derived from fossil fuels. It also appears that there's a high level of stress and overconsumption that's occurring on our planet. This graph right here, this figure, shows that in the 1970s, this is based on work from the Global Footprint Network. In the 1970s, we were consuming resources across the planet at a rate that was basically regenerating. So for every year of resource consumption, the Earth's forests and oceans, agricultural areas, overall, we're able to regenerate over that same year. Today, we're consuming at a rate of 1.5 planets per year. And the moderate projections in terms of the rate that the world's economies are growing and how they're growing, we are destined to consume more than 2 planets a year. This is obviously fundamentally unsustainable. We also have an obesity problem. Especially, you look at that big red tomato up in the upper left-hand corner there. That's my country. It's the United States. And this chart is showing world consumption patterns. So when we talk about the consumption of 1.5 planet Earths per year resources, most of those resources are being consumed by the wealthy, industrialized nations, United States, Europe, Japan. Many of those resources are being consumed by the rapidly industrializing nations. And then there are many nations and a large portion of the world's population that are under-consuming resources, their economies are not developed enough to provide for basic human needs. So it's a problem of obesity and malnourishment, if you will, and inequality. So, what does this show us? What are some of the symptoms? Well, it looks like our patient is running a fever. The 10 hottest years on record, 9 occurred in the first decade of this century. And take a look at this symptom. This is Arctic sea ice. The white area is in 2005. The yellow line is where Arctic sea ice was in 1979. So climate change, which is what the disease is often called, is happening faster than scientists, than climate scientists were predicting. And this is one of the symptoms that's showing us that. One of the other symptoms was the slide I just showed you about the 10 hottest years on record being in the first decade of the 21st century. Take a look at what happened in 2010, and we could have a very similar slide for 2011 for that matter. Floods in Pakistan affected 20 million people. Floods in China displaced 12 million people. A drought and fires in Russia took the wheat harvest down by 30%. And there were 56,000 extra deaths in Moscow and Western Russia. There were record temperatures in 17 countries. So we know that the patient is sick, but behavior is not changing. In fact, it seems to be accelerating in a very destructive direction. This graph shows you the average mean temperature from 1850 through the present and projected to 2100. And there's 3 lines here. The low line is the target line for the Kyoto Protocol and basically all the international climate negotiations, which is a 2-degree centigrade rise in temperature. This is what climate scientists thought might be safe. It's the world we're living in now, where we're beginning to see accelerated impacts of climate change that are already having profound effects on societies around the world. This is the 2-degree scenario that we're living in now. The problem is that I was just in Durban at the climate negotiations, and pretty much everybody is conceding that we're not going to hit the 2-degree scenario. We're looking more like we're moving toward a 4-degree scenario, which is above the central estimate and below the high estimate, or perhaps above. So I ask again, can you have healthy people on a sick planet? Here's the answer from Ban Ki-moon, the Secretary General of the United Nations. He says, our health, well-being, and sustainable future depend on this intricate, delicate web of ecosystems and life. Indeed, I would argue that the environment, excuse the typo there, please, is a major social determinant of human health. And in fact, the World Health Organization, in a very conservative study, suggests that environmental factors are equal to more or less 1/4 of the global burden of disease. Now, that's a broad definition of environmental factors. It includes car accidents and other factors like that, but it also includes pollution of air and water, cancers, other contamination, other what we would call environmental impacts. A lot of this is wrapped up in an ongoing development crisis in the world. 2 billion people today are without access to clean cooking fuels. More than 1.5 billion people are without electricity. More than 1 billion people have poor access to fresh water. About 800 million people are chronically undernourished. 2 million children die per year from diarrhea. And there are 30,000 deaths each day from preventable diseases. And part of it is overlaid by what we might call a modern industrial crisis. So according to the World Health Organization, nearly 1/10 of all preventable diseases or deaths in 2004 were caused by toxic substances. We're talking about here a chemical exposure that has been clearly linked in the scientific literature to asthma, infertility, learning disabilities, Parkinson's disease, and cancer. In fact, a substantial portion of cancer, or percentage of cancer, can be attributed to environmental and occupational exposure. And the majority of cancers now are in low and middle income countries. So this industrial disease is being globalized. And the proportion in low and middle income countries is increasing. So these are some figures from the United States, but as I just mentioned, we're seeing a real shift in where the greatest proportion of cancer is. So while this research comes from the US, it may well be applicable to much of the rest of the world, if not now, then sometime soon. The lifetime risk of cancer is 1 in 2 for men and 1 in 3 for women. The risk of breast cancer has tripled from more than 1 in 20 to 1 in 7 in the last 40 years. Non-Hodgkin's lymphoma has nearly doubled since the 1970s. Endometriosis, linked to dioxin exposure, now affects 10 to 15% of the US female population. Those are pretty serious figures. And on top of this, not measured in the WHO study that attributed 1/4 of deaths to environmental factors, climate change. The biggest global health threat of the 21st century, according to the Lancet. And many of you are aware of the health impacts of climate change. It's been well documented in the literature, and there's much more documentation coming out as things evolve. But one way to look at it, I would suggest, is that climate change is amplifying existing health risks and existing health impacts. So we're seeing an increase, and we will continue to see with climate change an increase in heat-related illnesses and death, extreme weather-related injuries and mortality, aggravated chronic illnesses, infectious diseases, migration vector-borne diseases, zoonotic diseases, water and foodborne diseases, increases there. Increases in asthma and respiratory allergies and chronic respiratory disorders. Increases in malnutrition and child development complications. Stress-related and mental health disorders. Population displacement and migration. And instability and conflict. And once again, the source of the problem and the impacts are very unequally distributed. So this first map up here is where the greenhouse gases come from. The bigger and more distorted the country, the greater the source of greenhouse gas per capita. And then the bottom map is where the impacts are being most severely felt. So, for instance, in my country, there are impacts. Hurricane Katrina is, in a sense, a wake-up call. It's the beginning of the age of global warming for the United States. There were serious impacts, health impacts from that. We're seeing the appearance of dengue fever in southern parts of the United States where it didn't exist before. But in Africa, we're seeing the potential for much more severe drought and famine as a result of climate change. And the impacts are going to be much more severe in the places that didn't cause the problem. So, all this is a bit of a preamble, and I don't mean to take you down too low, but it's the reality. But it's a preamble to the question of what is the role and responsibility of the health sector in addressing what may be the most profound crisis of our time. What do hospitals do? What do health-promoting hospitals do to respond to climate change? We need to adapt. There's no doubt there's going to be a heavy burden on the health sector to address the health impacts of climate change. But we also can take some proactive measures. Here's what Margaret Chan, Director General of the World Health Organization, says. She says, the health sector must add its voice loud and clear. We must fight to place health issues at the center of the climate agenda. We have compelling reasons for doing so. Climate change will affect in profoundly adverse ways some of the most fundamental determinants of health: food, air, water. I'd like to take it a step further. I would like to suggest that hospitals can move from being part of the problem to part of the solution. Part of the problem, you might ask? Hospitals, part of the climate change problem? Well, I think many of us are aware that we live in a bit of a paradox when it comes to the role of healthcare and its relationship to the environment. In fact, healthcare has a significant ecological footprint and a significant climate footprint. So here are some very brief examples. The National Health Service in England is responsible for 26% of public sector greenhouse gas emissions. 8% of US emissions come from healthcare. 10% of Brazil's energy consumption comes from hospitals. The US healthcare sector is the largest consumer of carcinogenic chemicals in the country. China spends $10 billion a year on healthcare construction. And half the world's population is exposed to the negative health impacts of medical waste. So yes, we are, in some ways, part of the problem. And so the question becomes, how do you break that vicious circle where we're providing a cure at the front door and contributing to disease out the back door. And I would like to suggest to you that this map gives us a clue as to both the problem and the solution. This is World Health expenditures, and the map by different colors shows the percentage of GDP that, that different countries spend on healthcare. It averages out to 8 to 10% of global GDP is spent on healthcare. So of course we're part of the problem. We are operating in a modern industrialized society in many parts of the world, and our hospitals are part of that system. But we can also be part of the solution. The health sector has a tremendous amount of economic leverage. If we change our patterns of production and consumption in the healthcare sector, we can shift entire economies. So this is my message for the evening. Hospitals can lead by example. We can promote public health by reducing our environmental footprint. And in fact, the good news here is hospitals around the world are doing great already. So a couple of examples. Yesterday we had this pre-conference on global green and healthy hospitals, and there were a lot of different examples from all around the world that were given, but here's some broad examples. The National Health Service in the UK has created a route map for sustainable health, and they've committed to reduce that 26% of public sector emissions by 10% by 2015, 26% by 2020, 80% by 2050, meeting the government mandate and providing moral, political, and economic leadership in their society. In the United States, last week, my organization, Healthcare Without Harm, and several others, launched the Healthier Hospitals Initiative. 11 of the biggest health systems in the United States, representing 500 hospitals, committed to reducing their environmental footprint by achieving a series of different goals. There are conferences now, conferences the size of this one or even bigger, on sustainable healthcare. So one's called CleanMed. It's the premier environmental conference for leaders in healthcare sustainability. Again, my organization, Healthcare Without Harm, is involved. There's one in a couple of weeks in Denver, Colorado, and especially for all of our European friends here and for our Taiwanese friends as well, I'd like to invite you to Malmö, Sweden in September to the CleanMed conference to learn more about and participate in discussions about sustainable healthcare. This is not just something that's happening in the industrialized world, however. WHO has become very involved in promoting green in the health sector. Thailand has a program, and there were several high-level officials here yesterday from the Thai Department of Health. It's called Green and Clean Hospitals. There are more than 800 Thai hospitals engaged in this effort to reduce the Thai healthcare sector's environmental footprint. Here in Taiwan, there are 128 hospitals committed to a lower carbon pathway. And we've heard a number of examples in the last couple of days of the excellent work going on here in Taiwan. And of course, there is the Health Promoting Hospitals Network Environment Task Force, which is working to move this network toward greater sustainability. So yesterday, at the side meeting, at the pre-conference, we launched the Global Green and Healthy Hospitals Network, which is an effort to bring together all of these different efforts at sustainability from around the world. It's based on the Global Green and Healthy Hospitals Agenda, which is a comprehensive environmental health agenda or framework for hospitals and health systems from around the world, and it has 10 goals. 1, to prioritize environmental health and provide leadership. 2, to substitute harmful chemicals with safer alternatives in hospitals. 3, to reduce, treat, and safely dispose of healthcare waste. 4, to implement energy efficiency and clean renewable energy generation. 5, to reduce hospital water consumption and supply potable water for patients, staff, and communities. 6, to improve transportation strategies for patients and staff and reduce carbon footprint in that way. 7, to purchase and serve sustainably grown, healthy food. 8, to safely manage and dispose of pharmaceuticals. 9, to support green and healthy hospital design and construction. And 10, to buy safer and more sustainable products and materials, and to take advantage of our tremendous purchasing power. So already, really just in a few months since we began building this thing, hospitals, health systems, and health organizations representing the interests of more than 2,500 hospitals from 5 continents have come together to form this network. Some of the members, FHI 360, which is a global health NGO, the Health Promoting Hospitals Network, you guys know that one? Environment Task Force, the Healthier Hospitals Initiative in the US that I just mentioned, the Indonesia Hospital Association, representing 1,200 hospitals in Indonesia, the UK, the Sustainability Unit of the National Health Service, and Synergy Sun Environment from Canada. More than 50 hospitals are already signed up or in the process of signing up. I think it's more like 60 or 75 since yesterday. About half are HPH members. We had 33 HPH hospitals join onto this network yesterday. And there's a picture of the launch ceremony from yesterday. You might recognize some of the characters in there. So by joining the network, hospitals and health systems are committing to achieving 2 of those 10 goals, or to working on them, and to reporting back on a yearly basis with data on how they've achieved those goals and information on how they've achieved those goals. Hospitals are being provided with tools and resources for implementation. There will be a space on the greenhospitals.net website to post case studies of success stories. What we're trying to do is create a global learning community to build synergy between these different efforts and to scale up the effort for sustainability in the health sector around the world. So you are all welcome to join this network. You can go to greenhospitals.net and be part of the solution. And really, my message is, we as the health sector must lead, because we cannot afford to have a sick planet, and we cannot have a healthy population on a sick planet. We must help lead the way to a green and healthy future through education, through leveraging our economic power, through reducing our own ecological footprint, and for advocating for an equitable low-carbon development path beyond just our own hospitals, but raising our voice as healthcare professionals and healthcare institutions for transformation of how we produce and how we consume resources on this planet. We must have a vision. And part of that vision is envisioning our own buildings as instruments of public health. We heard about Hospital Piedras Rosadas last night from Dr. Amral from the World Medical Association, which is working to support the transformation of the community around it. And there are so many examples now of hospitals reaching out to their community, not just to provide basic health services, but to support sustainability in those communities and to support health, environmental health in that regard. From the way the hospital is built, all the way through reaching out to the community and its relationship to the ecosystem in which it's built. And this vision is known as regenerative healthcare. The idea is that we're in a stage where we're moving more toward green design of hospital buildings. We're aiming to become more carbon neutral, have living buildings, but the next step is really envisioning our hospitals as regenerative buildings, buildings that give back to the environment and give back to the community. So I will leave you with that thought. Xie xie.
Thank you, Dr. Gloria. We have a little minute, but we allow several questions. Anyone want to ask any questions for all the speakers?
My name is Hadi and I'm from Indonesia. I would to ask a question to Randa. I'm glad that you finally mentioned Mother Baby Friendly Hospital, because it is indeed Mother and Baby is a diet. I just want to know, at a global level, early initiation of breastfeeding, is it within 1 hour or between 1 and 2 hours? What is the agreement? Thanks.
The initial 10 steps was initiated breastfeeding within half an hour. But as we gained experience and we collected the evidence and the science behind it, like I presented, for step 4, it's no more the case. We have a new interpretation for that step, and this is let it be a baby-led process. What's important is not to push it or start within half an hour, is to provide the skin to skin and let the baby decide when he's ready to start the first breastfeed. But usually it is within 1 hour. 1 hour. And this is included in the assessment tools that we have for the baby. Okay? And I agree with you about the baby and mother. It's high time we do that.
Okay.
My name is Margareta Gustafsson from Sweden, and I have a question for the last 2 speakers, or maybe Clemens Postman, because you spoke beautifully about how we need to prevent mental health on different levels. But to me, it was mainly on the individual level. And if we take the last presenter who says, can we have health people on the sick plan? My question is, when we have this rise in mental ill health over these years, what do you think about the change of exposure to different kinds of stressors, to the difficulties in managing a new way of living, which is basic social determinants of ill mental health, and how you would consider that we as a health system should act on that?
I think that's a very important issue that you are raising. The fact that have talked about prevention programs and mental health promotion programs that are especially individually focused has 2 reasons. First of all, mental has, of course, a lot to do with individuals and their competencies, and we all learn, and so such competencies can be learned, and we can stimulate that to be learned. Secondly, the reason is that given the need for evidence and given the current or past rules for providing evidence, most of these studies are randomized controlled trials, which means more or less that you are defined to individual interventions or small group interventions. Third, a lot of these interventions are still provided from the health systems. And I've worked for 40 years with those health systems. You are allowed to do prevention as long as you stay within the culture of the traditional health and mental health services. But so that's an explanation why it is there. I completely agree that we need to move to address also social determinants. And to give you just one example, the child abuse is, of course, something that happens between a small number of people, but is a social problem. It has a lot to do with societal values and so on. Now there are several programs. For example, I don't know if you are familiar with Triple P. Triple P is a worldwide program on parent education, using mass media, using healthcare systems, using internet, using all kinds of tools to create, at one hand, a kind of a movement to better parenting, and on the other hand, to help parents to empower themselves to do a better job within their family. And in the United States, there have been done a large-scale study where not now individuals are randomized across experimental and control conditions, but where whole states and districts were randomized across triple P or not triple P. And in the end, it was shown that in the districts where this whole triple P system, with all the involvement of all the different social health systems and mass media was implemented, there was a drop in child abuse and neglect of something like between 20 and 25%. And if you know the research about the impact, the long life impact of child abuse on children and later adults, that's tremendous. It has a lot to do with a risk on psychiatric problems, but it also has to do with the risk 20, 30 years later on higher risk of chronic physical diseases. So if you can, by just such an example, make a change, I certainly would go for that. So we need to go from individual and separate interventions to clusters of interventions. I'm very happy with this forum where different people are contributing pieces of the jigsaw. And also my left neighbor doing an appeal about the link between the health systems and the environment. It is about the same kind of value. So what we are doing here in this conference is also not only sharing individual and small tools, but developing a movement. Like the environmental movement was a success, we need to have a wider health movement, not only of professionals and researchers and policymakers, but also of large group of citizens and consumers, and make it really a worldwide movement that will make a change. And we should not focus on separate problems, but the different problems that has been discussed today and tomorrow are highly connected. And you can also make a story about the whole issue of poverty, or the whole issue of globalization, impact of globalization on family systems in Africa is enormous. It has an impact on migration. It has an impact on family life. Fathers or mothers who travel to another country or another continent to find work, to increase of child abuse, increase of neglect. We know that these kind of influences have also an influence on the genetic transmission systems in children and on the brain. So we're creating a lot of problems by letting it go. So let's join forces and also in this conference find ways to support these kind of actions.
Okay, any questions? Okay, thank you. Before we end the section, on behalf of the conference committee, Dr. Cole and me will send some presents for our speaker. Okay, if you move out to the stage.